Thank you for having me. Thank you for the wonderful introduction. For those who don't know, so as described, I'm a PGY4 at UT Southwestern and created dual neurology and psychiatry residency program there. I figured with the title of this conference being Autoimmune Encephalitis, the bridge between neurology and psychiatry, I could maybe talk a little bit about building that bridge and what that means. This is an area in which I'm obviously very passionate, so much so that I decided to add 2 more years to my life, much to the chagrin of my wife. And so I am also very interested in autoimmune disease of the brain and actually have a great passion. And I think it's a great example of where the two fields intersect. It was largely serendipitous that at UT Southwestern we had 2 program directors in psychiatry and neurology, Adam Brenner and Steve Vernino, who many may recognize the names of, who were open to my proposal for this combined program. And we already had very strong academic programs in each department at the time. Furthermore, we already had an autoimmune neurology fellowship there, one of the few in the country, headed by Steve Vernino, Ben Greenberg. And furthermore, he and Dr. Carol Tominga, who's our chair of psychiatry, were collaborating on research, which we're now still working on together. I should note that I don't speak on behalf of UT Southwestern. I'm not speaking on behalf of Parkland, who's the county hospital, who's my employer, but I'm my own free agent today, which I get to rarely say. I'm really thrilled to be here. I feel like I'm surrounded by giants. These are people whose names I've read in my academic infancy growing up. So I'm like a kid in a candy store right now. And I'm just really honored to be involved and to be up here. In terms of disclosures, I sit on an advisory board for an R1 at Stanford, and I'm, as Susan mentioned, part of the board of directors for HESA, which is a non-paying role and it's non-contributory. To give you kind of an idea for my hope of this talk, I really want to pique your interest, get the day started off with kind of an overview and something to whet your appetite for the amazing speakers that are to come. I really want to kind of cover 3 major tasks. First, I'd like to give you a scenic walkthrough of the rich and storied history of neurology and psychiatry, kind of how they started and where we're going, which leads us to modern neuroscience and autoimmune encephalitis. And then finally, to kind of go from the present to the future. So to start, I think it's important to know the framework in which we're working. So we'll touch a little on the history of neurology and psychiatry. I was lucky enough in my interviews for residency to meet Dr. David Silberswag, pictured here, who's the chairman of psychiatry at Brigham and Women's and is a dual-boarded neurologist psychiatrist. He wrote this, so he's been a mentor of mine, which I'm very lucky about. And he published a great piece in JAMA Neurology in 2017 called Integrating Models of Neurologic and Psychiatric Disease. And in that he said, traditionally, neurology has been concerned with known or observable neuropathologies, while psychiatry has been concerned with idiopathic psychopathologies. I think that says a lot. Similarly, Dr. Jeff Lieberman, who many in this room may know, chair of psychiatry at Columbia, who I was lucky enough to get to do a focus group on destigmatizing psychiatry with, and who's also the author of a really good book called Shrinks, The Untold Story of Psychiatry, which I highly recommend. He said in that book that neurologists work in the domain of disorders with an observable neural stamp, whereas psychiatrists work in, and he said, this is his word, invisible disorders of the mind. So really, looking at the history of psychiatry and neurology, it's easier to find early history for psychiatry than neurology. In the 4th to 5th century BCE, the Greeks and Romans had started, the Greeks first, talking about psychiatry. And here, these statues depict what is called melancholy and raving madness. And these statues used to be present in the famous Bedlam Psychiatric Hospital. Profound manifestations of illness, such as psychosis, were actually viewed as supernatural by the Greeks and Romans, and so they approached things like exorcism and other religious rites as cures, which didn't work, as we know. Then moving on, the earliest recorded text talking about mental illness is from India in the 3rd century BCE, which coincidentally is also where the first mental health hospitals were begun. Fast forward a few centuries, in the Islamic Golden Age, the 8th to 14th centuries, Common Era, they focused on mental illness, and there was a gentleman named Abu Zaid al-Baki. I apologize if I butcher, and there's several other names I may butcher this morning, so I'll do my best. But he classified what he called neurotic disorders, into 4 different groups: fear and anxiety, anger and aggression, sadness and depression, and obsession. Moving forward, we got to the mid-17th century, and the famous English physician Thomas Willis, who was an English doctor and pioneer of nervous system anatomy, he introduced us to the eponymic circle of Willis, which was included in his Cerebri Anatomiae of 1664, and he actually coined the term neurology. Moving on to the 18th and early 19th century, Robert Whytt was a Scottish physician and neurophysiologist who interestingly argued against René Descartes, who Descartes had a theory that muscles contracted due to activation of fluid in the nervous system, which he called animal spirits. And so Robert Whytt had decapitated frogs and put a hot wire in them, inducing movement in their limbs, but he found that that only happened when the spinal cord was present, and when the spinal cord was removed, the limbs no longer responded to stimulus, so he helped give us some information about the importance of the spinal cord. Also in that time period, Franz Josef Gall came along, who was a German neuroanatomist and a pioneer of the study of localization of mental function, most famously known for phrenology, or the science of interpreting bumps on the skull to predict mental traits, which, despite being total hogwash pseudoscience, did propel psychiatry into the limelight as a science. The 19th century then was also full of pioneers of the brain. Sir Charles Bell was a Scottish surgeon and neurologist who discovered the difference between sensory and motor nerves and introduced a phenomenon which we now refer to as Bell's palsy. Moritz Romberg was a Jewish physician from Berlin who was the first to document tabes dorsalis, or the involvement of syphilis in the dorsal spinal cord. And he also, as you can imagine, came up with what we now call Romberg signs, still used in our neurologic exam. This next one is a doozy, so bear with me, but Guillaume Benjamin Amand Duchesne de Bouillon, I have no idea if that's close, was a French neurologist who advanced electrophysiology, and he pioneered nerve conduction studies in clinical photography, here demonstrating the mechanics of facial expression, which were the first studies on the physiology of emotion, and interestingly were highly influential on Charles Darwin. Further into the 19th century, William Hammond was an American physician who became the 11th Surgeon General of the US Army, and he was the first American physician to be solely a neurologist, going on to be one of the founders of the ANA. He actually, though, studied lithium in mania, interestingly. We then encountered John Jackson, who was an English neurologist who studied epilepsy and introduced this concept known as the Jacksonian March. Then came along Paul Broca, who was a French physician who discovered an area of the dominant frontal lobe that, when damaged, caused an expressive aphasia. And this was really the first anatomical proof of localization of brain function. Then his counterpart, Carl Wernicke, demonstrated a similar lesion in the dominant temporal lobe that caused a receptive aphasia. The discoveries of these two gentlemen kind of opened the door for people like Corbinian Brodmann, who was a German neurologist and famously cut the brain into 52 distinct regions, which we now call the Brodmann areas. In 1844, psychiatry was actually established as the first medical specialty. And in that same year, the first medical specialty society of the United States was formed. So here's the name: the Association of Medical Superintendents of American Institutions for the Insane, which after a few name changes became known as the American Psychiatric Association, which is still the longest running medical society. In the latter half of the 19th century, up until the end of World War II, is an era that I like to call the first era of neuropsychiatrists. So I kind of want to play a little game. It involves you waking up a little, and I kind of just want people to shout out. But what I'm going to do is name a famous clinician or neuroscientist and maybe just a few of their seminal contributions, and you just guess, is this a neurologist or psychiatrist, okay? So let's start. Jean-Martin Charcot was famous for many things, including work in hypnosis and hysteria. Neurologist. Arnold Pick discovered frontotemporal lobar dementia. Psychiatrist. Joseph Babinski had an eponym named for him regarding a pathologic reflex elicited by stroking the ventral side of the foot and watching the hallux due to damage to the corticospinal tract. Neurologist. Emil Kraepelin, who separated psychoses into manic depression and what he called dementia praecox. Psychiatrist, and actually also called the founder of modern scientific psychiatry in many circles. Sigmund Freud, the founder of psychoanalysis, who described the psychosexual stages, oral, anal, phallic, etc. Neurologist. It's where things get tricky. And Alois Alzheimer, who in 1906 showed plaques of beta amyloid and neurofibrillary tangles of misfolded tau protein that correlated with symptoms of amnestic dementia. Psychiatrist. And I think this goes to show my whole point, which is nowadays, I think you wouldn't have any throwing you off like that. But in this era, it was very common to maybe have primary training in one specialty, but tending to be interested in both fields, holding dual appointments, pursuing studies in both areas. And so you can just see that overlap demonstrated beautifully here. This is actually a famous painting called A Clinical Lesson at the Salpêtrière. And pictured here in the middle is our famous Charcot, who was attending at that time and showing this hysterical patient who's actually being held by his chief resident. Does anyone know who that is? That's Babinski. So that's a pretty famous painting. By the 1930s, the field of neurology had clear clinical diagnoses, including some neuropathologies. The neuro exam had been refined. CSF analysis and EEG had become really powerful tools. However, these started to become the turf of neurology, and a distinction began to form as psychiatry began to distance itself, focusing on syndromes and symptoms without having any sort of objective markers such as pathological diagnoses post-mortem. And so at this time, the distancing began, and this is what I like to call the age of the brain versus mind. Really, in this time, we're just getting to post-World War II. There's a mass emigration of psychoanalysts from Europe to the United States. And with that, they brought the mentality of psychoanalysts for better or worse. So that school began to dominate the American psychiatric landscape and left behind the biological roots and the tools and knowledge of neurologists largely. To kind of demonstrate further this age of brain and mind, up until the 1950s, Harvard had a single unified department that included neurology, neuropathology, and psychiatry. It was headed by people who may be known well to this room, such as Derek Denny Brown and Raymond D. Adams. Most of these prominent leaders had training in both neurology and psychiatry. Interestingly, one of the goals of this department was actually to ensure that psychiatry could overcome stigma and isolation from other fields by promoting integration between the fields, and they even had interdepartmental meetings, et cetera. But unfortunately, in the late 1950s, largely due to the growing influence of the psychoanalysts, the joint department was disbanded. In 1965, there were concerns raised by the Residency Review Committee for Psychiatry and Neurology that neurology training programs were not offering adequate psychiatric training. Despite this, neurology then eliminated mandatory psychiatric training for neurologists. In 1970, psychiatry likewise abandoned the internship year, including all general medical training, citing that, quote, psychiatry had moved away from medicine, and therefore, after a few years of practice, the average psychiatrist did not use skills previously acquired. Internship did return in 1978 with some medicine, but a mere 2 months of neurology. At this time, terms such as organic versus psychogenic or functional began to become in vogue, delineating the disease of the brain from that of the mind. In fact, the former president of the ABPN, Dr. Francis Braceland, said of the 1950s and 60s, to get neurologists and psychiatrists of that period in time to sit down together without police present was in itself an accomplishment. However, fortunately, other forces were in play at that time. In the UK, some of the earliest descriptions of autoimmune encephalitis began to enter print. Brierley et al. Published a paper on subacute encephalitis affecting predominantly limbic areas. This was followed in 1968 by a paper first authored by Corsellis on limbic encephalitis in association with carcinoma. The following year, Gilbert Glaser and Jonathan Pincus from Yale wrote a case series on limbic encephalitis, actually at one point mentioning many of these patients had been considered to have functional psychiatric disorders prior to the discovery of these pathologies. Also seemingly in the background was a small group of psychiatrists deemed biological psychiatrists. In the late 1960s, Danish birth registry studies looked at the prevalence of schizophrenia in adoptive and biological relatives of probands, and began to kind of elucidate the contribution of both environmental and genetic factors importantly challenging one of the big psychoanalytic notions that there was a schizophrenogenic mother, for instance, and that parenting styles or environmental conditions could cause these things. There were other labs that were deep in medical experimentation as well, and they slowly but steadily began to pave the foundation for modern neurosciences, such as when the study of kittens unilaterally deprived of vision demonstrated reorganization of their visual cortices, which showed us brain plasticity. Furthermore, biological psychiatrists laid the background knowledge in psychopharmacology that led to the advent of treatments such as our first antipsychotic pictured here, chlorpromazine or thorazine in the 1950s. This had initially been used as a surgical anesthetic. So biological psychiatrists largely used the tools of medicine and neurology and were not shy away from that, unlike the rest of the field. And in fact, this group then went on to develop and help develop many of the antipsychotics, antidepressants, anxiolytics that we still use to this day. But at that time, the field of psychiatry actually viewed these maybe as an adjunct to psychotherapy at best. All of these pioneering steps, however, helped us blaze a trail. Hopefully I still have your attention because I think it's an exciting story. But now we enter the 1970s, which was a really exciting era for neuroimaging innovation. In 1971, Paul Lauterbur applied magnetic field gradients in 3 dimensions to create nuclear magnetic resonance images. He first published the images of 2 tubes of water in Nature, followed by the picture of a clam, and then ultimately in 74, the thoracic cavity of a mouse. He called this method, and I think it may have been appropriately pronounced zoigmatography, but fortunately for us, it got redefined and called MRI. The first commercially viable CT scanner was introduced by Sir Godfrey Hounsfield in 1972. And fluorodeoxyglucose was synthesized at the Brookhaven National Laboratory in 1976 and has since become the most widely available tracer used in positron emission tomography. And it's contributed to our understanding of several maladies such as epilepsy, dementia, mood, and psychotic disorders. Modern neuroimaging then really began to propel forward this understanding of illness of the brain, and many diseases that, again, had been considered functional now had structural abnormalities, which started to shake this notion that the brain and mind were entirely separate entities. Around this same time, psychiatry was preparing to undergo a dramatic makeover. Robert Spitzer led the APA's task force for the 3rd edition of the DSM, which released in 1980 and powerfully, but very controversially at the time, overthrew the psychoanalytic majority and started to redefine psychiatric illness by reproducible syndromes in an empiric Krepelinian fashion. Despite this, though, the fields were still across a chasm. Neurology trainees were and are, to this day, still only mandated to have 1 measly month of psychiatry training and 4 years of residency. Similarly, psychiatry residents spend a mere 2 months in neurology. And as such, we suffer from a paucity of dual-trained practitioners, instead having brain specialists and mind specialists. And that brings us to the modern era. Biological psychiatry is alive and stronger than ever. There's a veritable army of psychiatrist scientists. In fact, Carol Tominga, my research mentor, one of them, was president of the Society of Biological Psychiatry in 2018. She and the rest of her BSNP research consortium have reclassified psychosis, including psychosis related to depression, related to the schizophrenia spectrum of disease, and in mania, among others, essentially took these from syndromes and classified them into 3 distinct biotypes, which are defined not just by symptoms and symptoms by the patient themselves, but also by a lot of objective data, including neuroimaging, EEG, and biochemical markers. Holly Lisenby was inspired to improve upon electroconvulsive therapy and developed a new form of neuromodulation called magnetic seizure therapy, which is now in clinical trials. Helen Mayberg and Connor Liston, among other peoples, are a few the people who are studying the brain in a circuit network paradigm and shedding new light on mental illness. And speaking of light, Carl Dijsselroth developed a method called optogenetics, which is a modern research tool used to control neuronal activity via modulation of ion channels that are sensitive to particular wavelengths of light. And I just use these as demonstrations of some of the exciting directions that psychiatry has come in the last few decades. And finally, Michael Fox and others like him are actually using neuroimaging and other objective markers to both predict responders to neuromodulation, such as non-invasive brain stimulation, and then also to kind of moderate the treatments and be able to see, are there changes in networks with treatment? Actually, I think just yesterday I saw an announcement of one of his fellows publishing a paper in the Journal of, I think, JCNC. So our new holy grail in psychiatry now is precision psychiatry. It's really this idea that we are guiding our decisions by complex individual profiles rather than this historical population-based one-size-fits-all approach. So that's really what the field of psychiatry is looking at, and I think it's a beautiful step in the right direction. But similarly, neurology has grown and expanded in scientific advances. We've begun treating monogenic illnesses such as nusinersen or Spinraza for spinal muscular atrophy, which is an antisense oligonucleotide that selectively regulates gene expression, promoting a different type of splicing, and unfortunately is $1 million for the first year, but otherwise is an amazing treatment. We've harnessed the digital age with deep brain stimulation to treat things such as Parkinson's disease and essential tremor. And for the last several years, especially the early 2000s on, autoimmunity has been on the tip of everyone's tongue. Although it was initially maybe considered to be a limited field studying diseases such as myasthenia gravis and multiple sclerosis, our other esteemed speakers and many others in this room and watching from elsewhere have shown us that in the fringe between neurology and psychiatry are some of the most interesting disease processes we encounter as clinicians. Piggybacking on the work from the UK and Yale a few decades before, in 1988, Nobel laureate Kohler rekindled an interest in limbic encephalitis when he published 2 case reports in the Journal of Neuroimmunology. Shortly thereafter, our own Dr. Damau published a piece on detection of anti-HEU antibody in patients with small cell lung cancer. He and colleagues would go on in the next few years to publish results of a 50-patient study that began to explore encephalitis as a paraneoplastic syndrome in greater depth. The time from then to now has filled our medical lexicon with a host of new antibodies explaining previously unexplained phenomena, including the NMDA receptor, Caspr2, DPPX, and thyroperoxidase, or TPO. The field of autoimmune neurology has exploded into the limelight. In 2016, this was my favorite when I was putting this together. 2016, at least 3 of our authors were co-authoring a piece in Lancet Neurology, which is a really elegant piece I recommend checking out that regards the best way to approach the diagnosis of AE. As we've learned through their work and the work of others, antibodies to both cell surface antigens and intracellular targets have been found to cause seizures, memory problems, abnormal movements, and even coma and death. In addition, though, these misguided soldiers have decided to not respect our taxonomy that separates the neurologic from the psychiatric. And so they also perplexingly produce personality changes, psychosis, compulsions, depression, and catatonia. These maladies have really brought the fringe to the forefront as they've expertly wiped away our line in the sand. I was trying to be clever there. So Joseph Martin, a neurologist and the former dean of Harvard Medical School, said that neurology and psychiatry have, for much of the past century, been separated by an artificial wall created by the divergence of their philosophical approaches and research and treatment methods. Scientific advances in recent decades have made it clear that this separation is arbitrary and counterproductive. Neurologic and psychiatric research are moving closer together in the tools they use, the questions they ask, and the theoretical frameworks they employ. The interests of neurology and psychiatry converge within the framework of modern neuroscience. Further progress in understanding brain diseases and behavior demands fuller collaboration and integration of these fields. Leaders in academic medicine and science must work to break down the barriers between disciplines. Those are pretty strong words, but from a pretty powerful figure. I think that to that end, we're moving in a great direction. Psychiatry is really now returned to the fold and is heavily involved in evidence-based practices and experimental medicine, and actually has the technology to approach hypotheses about how the mind might be defined in biological terms, as all mental processes are ultimately biological. Neurology has begun to tolerate ambiguity and even began to embrace the functional, with the AAN's very weighty continuum even going on to state that the functional disorder should be the realm of the neurologist primarily, which is, if you're a neurologist in the room, know that that's a bit of a flip from what many of us had thought in the past. Interdepartmental collaborations are not only occurring, but they're frequent and very powerful. And so here we are. A new era is approaching, perhaps the second era of the neuropsychiatrist. Neurologic and psychiatric disorders will be classified, and from this point on, this is some of my speculative thoughts, and hopefully just controversial enough to get people excited, but I think I'm in the right room. But I think we're gonna have a new taxonomy for psychiatric disease, and it's gonna incorporate symptoms and signs, which it does now, but also exophenotypes, endophenotypes, including neurophysiological profiles, genotypes, biomarker batteries, and multimodal neuroimaging, and the biomarker batteries, importantly, including immune markers. I really think that by doing this and finding tangible neuropathologies, that will, in its very nature, eliminate and reduce much of the stigma with mental illness that we currently deal with now. When people have an answer for something, you can't simply say it's in your head or poo-poo it or make it sound like it's so simple and different from all the other diseases we treat on a day-to-day basis. So I'm hoping that It's All in Your Mind may go the way of the dinosaur. As such, though, it's important that trainees in these fields are exposed to the breadth of cerebral illness without blinders. For example, 2 months is not nearly enough to recognize the face of neurologic illness masquerading as psychiatric. Likewise, neurologists who on a daily basis deal with psychiatric symptoms have only limited training in a powerful armamentarium of psychopharmacology, including antidepressants, antipsychotics, and anxiolytics, as well as psychotherapy, knowledge which could enhance patient care. In my own practice, I've already encountered this innumerable times. I was going to share a personal anecdote. How am I doing on time? 2 minutes, okay, so maybe we'll do one quick anecdote. I had a patient who was an employee of UT Southwestern, and she got NMDA receptor antibody encephalitis, and as they tend to do at times, was having some relapses, bringing her to the ER. I saw her with Dr. Vernino as an inpatient. We managed to actually get her inpatient rituximab, which was wonderful. And then her family was trying to figure out what can we do as needed. And they couldn't obviously hold her down and give her Haldol injections. So we tried to pick something else. And with my psychiatric training, Dr. Vernino asked me, what do you think? And I said, well, I think we could, she's not maybe willing to take pills and swallow them at that moment, but she might put something in her mouth. So we got her oral dissolvable tablets of clonazepam and risperidone, and last I heard, she's doing great and hasn't been back. The Rituxan may be a very large part of that, but I'd like to think that my contribution with her PRN meds has helped her parents as well. Neurologists and psychiatrists work with a shared toolkit, but each are only utilizing part of the tools, I think. Even in the shared realm of mood stabilizers, which are often anti-epileptic drugs, are only known in part to either side. Neurology has powerful tools such as the neurologic exam, neuroimaging, EEG, and CSF. Psychiatry brings a depth of patient interaction, extension of the mental status exam, psychotherapy, non-invasive brain stimulation, and psychopharmacology. We've now entered what I consider the third North American psychiatric revolution in the past 100 years. The first was this transition to psychoanalysis with the immigration of European psychoanalysts. The second was the 1980 flip with Robert Spitzer and the DSM-3. And finally, now the age of the biomarker and precision psychiatry. Neurology has begun to embrace ambiguity and sought to supplement its already rich toolkit with the toolkit of the behavioral neuroscientist, which demonstrates both flexibility and willingness to change. Autoimmune diseases of the brain have proven to be a perfect substrate, illustrating the common ground shared between the fields. And I think this is why this is hopefully a pertinent talk for today, because autoimmunity is such a perfect place where these two fields intersect. And in fact, going back to what Joseph Martin had said about reunification, there's already a framework in place for reunification. There's the American Board of Psychiatry and Neurology. Every year I have to take 2 in-service training exams, one for neurology, one for psychiatry, and they're each some percent of the other. So there's already a governing board that covers both board exams. So as such, I don't think it's a great leap to presume that we could transition from a separate department of neurology and a department of psychiatry into a collaborative department of clinical neurosciences. My hope is for these 2 incredible clinical neurosciences to rekindle their former flame so that it grows into a torch to be passed to the generations of scientists and clinicians to come. Thank you all so much, and I'm excited to see what's in store for the rest of the day.